Pulmonary Drugs, Part 5. Welcome to the lecture. This is Dr. Phyllis Dumont. Two most common conditions that are seen acutely in primary care are upper respiratory viral infections, URI or viral rhinitis, and allergic rhinitis. There is evidence to support the use of decongestants, intranasal anticholinergics, and mast cell stabilizers, antitussins, and expectorants in the treatment of upper respiratory viral infection. For allergic rhinitis, there is evidence to support the use of antihistamines, intranasal steroids, intranasal mast cell stabilizers, and leukotriene receptor antagonists to help treat allergic rhinitis. Nasal symptoms with a viral URI respond to intranasal ipratropium bromide, intranasal cromolyn sodium, a topical or oral decongestant such as phenylephrine or pseudoephedrine, or a combination product containing an antihistamine and a decongestant. If a cough suppressant is needed, dextromethorphan or cough expectorant with guanefacin. Avoid codeine products for cough suppression in patients with upper respiratory tract infection. There's really no evidence of efficacy for acute URI-associated cough. It can be effective with chronic cough, however. Evidence practice for viral URIs continued. Avoid monotherapy with antihistamines. Avoid intranasal steroids or vitamin C. There really isn't any evidence to support their effectiveness. For different reasons, avoid zinc sulfate lozenges or syrup. It's uncertain benefit, and there are known toxicities, including irreversible anosmia, or permanent loss of your sense of smell. For common colds, of course, antibiotics are not indicated. Prophylaxis for viral URI? Well, keep immunizations up to date. Hand washing. Ill persons should avoid exposing others. There's scant benefit for vitamin C, except for persons exposed to vigorous activity in very cold conditions. There's minimal evidence for that. There's no real evidence to recommend echinacea or vitamin E for prophylaxis of colds. However, many of the trials on which this were based were small, and so they may have been too small or underpowered to pick up an effect. So if you have a patient who is using echinacea, for instance, and reports that they feel it really helps them, there's no reason to argue with that. It might actually help them. Mechanism of action for the decongestants. The decongestants are sympathomimetic amines. They stimulate beta-adrenergic receptors of vascular smooth muscle and cause vasoconstriction. So the effects of this are nasal decongestion, contraction of gastrointestinal and urinary sphincters, and pupil dilation, and decreased pancreatic beta cell secretion. Mimetic drugs, of course, mimic norepinephrine or sympathetic effector organs, affecting the adrenergic receptors. The mechanism of action of decongestants for Sudafed and phenylephrine. It's an alpha adrenergic receptor agonist, a sympathomimetic. It produces vasoconstriction by stimulating the alpha receptors in the mucosa of the respiratory tract. It reduces tissue edema and nasal congestion, increases nasal airway patency, promotes drainage of sinus secretions, and opens obstruction in the eustachian tubes. Pseudoephedrine also is used in illegal manufacturing of methamphetamine. State and federal regulations now restrict the sale of pseudoephedrine. Mechanism of action of the antihistamines. They compete for histamine at an H1 receptor site. They're useful to treat IgE-mediated allergy, allergic rhinitis, and urticaria. They antagonize histamine. They have some anticholinergic, antipyretic, and sedative effects to varying degrees, more so in the so-called first-generation antihistamines than in the so-called less sedating or non-sedating antihistamines, which should really be called less sedating. So mechanism of action of the intranasal steroids. We've talked about steroids in the lungs, now in the nose. They have potent glucocorticoid and weak mineralocorticoid activity. They have direct local anti-inflammatory effects. They control the four major symptoms of allergic rhinitis: the rhinorrhea, congestion, sneezing, and nasal itch. They're useful in moderate to severe disease, seasonal and perennial allergic rhinitis, but they must be used consistently on a daily basis for effectiveness, and the maximum effects may not be noted for several days to even weeks. That's in contrast to some of the decongestants like Afrin, which immediately open up the nose, and so sometimes it's a little bit of a hard sell to get somebody to use something for a longer period of time without seeing any immediate results. The antitussives, what is their mechanism of action? Well, codeine and dextromethorphan act centrally on the medulla to suppress cough. Dextromethorphan is a D-isomer of codeine. It lacks analgesic and addictive properties. It's not as effective as codeine, though, in depressing the chronic cough. Benzonatate anesthetizes the stretch receptors in the respiratory passages, and this reduces the cough reflex at its source. That's Tessalon pearls.